One. Hey, it's Gonzo Gonzalez, and you're listening to Dr. Gonzo's Talking Points. Thanks for tuning in. Today, I'm really honored and excited to have a guest with me, a true pioneer, one of the world pioneers in total artificial heart technology, Dr. Jack Copeland. Jack, thanks so much for being on the show.
It's a pleasure to be here, Dr. Gonzo.
As a little bit of a backdrop, Jack and I met several years ago. Remember when I was in Cleveland?
I do remember that debate that we had. That
So
was very nasty.
well, hold on a second. But you know how that came about. Somebody
Yes.
came up with a bright idea that I was going to debate total artificial heart technology with you because they thought that the young buck could actually deal with the master.
So what happened? How'd it go?
Well, I think that from my point, it went really good. I think that you gave a great presentation, and back then, I remember sitting on at my seat waiting for my turn, and I was just getting burnt by text. People just texting me saying, "You're done." I thought it was fun. I thought it was a really good time, and I've always admired you and followed your career since I was in training. So now to have the chance to do this with you and have an interview with you is just basically a super cool thing.
Well, thank you.
Well, listen, so just for the listeners, so let's put the listeners in a little bit of a context. So total artificial heart technology has been around for years. And how was it that your career began in that technology? Because historically that whole several centers started developing total artificial hearts, right?
Yes.
And go ahead.
I just backed into it. It was an accident, really. I came out of a world that didn't really recognize mechanical circulatory support of any kind.
How so?
We were totally oriented towards heart transplantation. That was it.
Okay.
And that was gonna solve the problems. And this wild idea of putting a mechanical device into a patient was pretty bad. Was pretty definitively rejected by Dr. Shumway, who was not an artificial heart guy by any means. And
so, what does Shumway think it was? What do you remember about Shumway saying about total artificial heart technology back in the day?
After we'd put in a few, he said, Jack, I saw him at a meeting. He said, Jack, if you keep this up, we're all going to be in jail.
Okay. Coming from the man himself. All right. So then what?
So that's where I came from. And when I started in Arizona, it was I had no intention of getting into mechanical circulatory support. I was set on heart transplant, and at that time, heart transplant had a lot of challenges. It had been banned in most hospitals in the world.
Is that so? And why was that?
There was a moratorium on it because everybody died, and it was quickly realized that it was an idea that had started before adequate care of the patient, selection of patients, and so forth was available. And, so the first 100 patients pretty much died.
How long was that moratorium for?
Well, it went on for quite a while. It went on long enough that when I went to Arizona out of my residency and started a heart transplant program, we were the 6th program in the U.S. and the 8th program in the world. So there weren't very many programs around. There was Stanford, and Columbia had a little tiny program going on. There was a program in Wisconsin, one in Birmingham, Alabama, in a private hospital, Baptist Hospital. And I think that's about it. Oh, there was Richard Lauer, who'd gone to Medical College of Virginia. Of course, he and Shumway had pretty much invented the technique that was successful. And Lauer had been my boss. I worked in his lab for 5 years in medical school. It was a 5-year program. I got a job in his lab, and we did transplants every day. So I knew it worked.
Uh-huh.
And I was dedicated to the idea of making it catch on. And it certainly hadn't caught on at that time. So it was a bit of a struggle. But, what happened to me is we were very successful with heart transplant. Our first dozen patients all survived and went home.
Okay.
That was unheard of, to have 12 in a row that did well.
What did you do right to get those 12, other than surgical technique, I guess, immunosuppression?
Yeah, I think the two things that really made it work were better selection. We didn't take people who had no chance of surviving. Initially, when heart transplantation got started, people were afraid to use the technology in people who were somewhat stable. In other words, if they had any chance at all of being treated some other way, they did that first. And so as a consequence, the people that came for transplant were pretty much moribund, and there really wasn't much of a chance of saving them. So what we did is we began to pick and choose, and we came up with selection criteria. We published selection criteria in Circulation. Interestingly enough, the selection criteria 30 years later read almost like the selection, the guidelines from the International Society for Heart and Lung Transplant read pretty much like what we had written in Circulation in the early to mid 80s.
And I don't want to digress much away from the TAH, because I really want to, but it's interesting to me how now we're looking to try to revamp the selection of donors now to try to work so it's survival of the sickest rather than survival of the fittest, right?
Exactly. And, I think that's always where the Judeo-Christian ethic has been, is take care of the sickest people first.
Yeah.
And, it's a pretty simple idea, and it's one that I think is very valid, but to some extent, I think it's being rejected nowadays because there's so much oversight of heart transplantation by various people, mainly UNOS. And if your track record isn't exceptionally good, you stand a pretty good chance of being put on probation and lose.
Well, and it'll
that's
be
a whole big story.
That's a totally different conversation, but one that right now we're facing. But let me go back to the total artificial heart.
Well,
so
let me just make a connection with total artificial heart, because my feeling is that's pretty much where we are with total artificial heart now. We know the technology works. That's why I started using it, because it worked, and I'll tell you that story in just a second.
Okay.
But we know it works. Then, why hasn't it been widely adopted? Well, it's the same story that heart transplant went through, but worse. People choose the absolute worst candidates, and they wait too long, and then they do the procedure, and they have a bad result. So that's, selection is extremely important. But the way I got into this is, I was a transplant guy. I'd done 12 transplants in Arizona. We were one of the few programs in the world, and catching a lot of heat from everybody around, particularly people in Arizona. And we had 2 patients in a row who died on the table of primary graft failure. And I was terribly depressed. I almost shut the program down. And I said, if this ever happens to me again, I'm going to do something. I wasn't exactly sure what I was going to do, but I'm not going to let it happen again.
Okay.
So, about 4 or 5 transplants later, we had a guy who really badly needed a heart, and there was a donor in town. And interestingly enough, Chris Cabral and his wife were visiting in town. Chris was the first one to do a heart transplant. And I asked Chris and Anique, his wife, who's an anesthesiologist and essentially ran their transplant program, would you take this donor? They both said, no, Jack, the white count's down, and he's a little bit febrile, and this could be sepsis. I said, no, this guy's so sick, I'm going to take the donor. So I did.
Right.
And a day later, he had 6 positive cultures for Pseudomonas. The heart never worked, and we kept him on bypass and started calling. And we called Phoenix, and Saivon had the Phoenix heart. It had never been put in a human. It wasn't approved. And then we called Salt Lake, and they had the Jarvik, and it was approved, but nobody had put it in except DeVries. That's
Right.
a permanent device. So both of them came flying to us, and the Salt Lake people made a big publicity about this. They called all the TV channels and whatnot. So, they arrived just a little bit before NBC, CBS, and ABC, and the New York Times, and so forth, because here we were putting in total artificial heart in an emergency condition. Turned out that the Phoenix heart arrived first, so we put it in, and I helped Cy Vaughn put in that heart. I didn't know anything about it, but
Okay.
I wasn't going to let the patient go, and darn if it didn't work very well. Kept the patient alive. We did a transplant on him a few days later, but it was in vain because he also had multiple positive blood cultures for Pseudomonas. So it didn't work, but that got us thinking that this technology works. If you have a failed graft, what other option do you have?
Right.
And so we went off and trained on the Jarvik heart in Salt Lake City. And in around August of that year, along came a young man who was equally sick, and we put in the total heart, and we transplanted him 9 days later. The heart worked beautifully, and he did well. He lived for almost 6 years. He died of lymphoma, sadly.
So you already had two TAHs under your belt at that time.
Well, this was the second one, yeah.
Uh-huh.
And that was 1985.
So what was going through your mind then about the technology?
Well, the technology works. You put it in an appropriate patient, and it keeps them alive. Their kidney function is okay. Their neurologic function is okay. They do well. So we thought, well, let's use this. We also, at that time, we had the Thortec, the LVAD, the BIVAD.
Right.
We had external the external Symbion device. So we had all the bases covered. We could do an LVAD, we could do a BIVAD, we could do a total artificial heart.
Right.
And so we started formulating selection criteria. And basically, we looked very carefully at right-sided failure. We looked at dilatation of the right ventricle. We looked at right ventricular ejection fraction. We looked at first pass ejection fraction on nuclear studies.
Right.
And so forth. And but mainly, you just walk in the room and you look at the CVP, and you look and see the patient has edema, and
Right.
And his PA pressure isn't all that high, so you know for sure his right ventricle is failing.
Right.
And those patients, if they were going down rapidly, we would put in a total heart. And an example of that would be a guy that's been evaluated for a heart transplant. He's waiting in-house because he's sick. He has a cardiac arrest. We start giving him compressions. We put him on ECMO. Then, instead of sitting there on ECMO, why sit on ECMO with a guy like that? What are you going to do besides make him worse?
Right.
We ran him down to the OR, and we put in a total artificial heart. That guy's walking around Yuma, Arizona, 20 years later, and he's doing fine. He's doing fine.
Now, I would have actually pushed back a little bit there, because I would have said, well, you don't know what his brain's like.
Well, we knew his brain was okay because we were right on him. And, he was actually struggling and trying to move his hands and so forth.
Okay. So you had evidence that at least he wasn't like, his brain wasn't gone, or he had a stroke or noxious brain injury. Okay.
In these kind of events, the main thing you want to look for is evidence of neurologic damage.
Right.
That's irreversible. And if you have evidence that the patient's moving around, that's pretty good evidence. And you're right there, and you've seen the whole thing, and you know he's had pretty good support during the period of resuscitation.
Just like witness arrests that we see, that we talk about. Yeah.
And one of the next patients we did was, I probably shouldn't say this, but I will.
Okay.
A patient who he was a mismatch. Those were back in the days when there was no computerized publication of the patients.
Right.
Where we kept it on a blackboard in a room in the hospital, and we had and that was where our donor list was. There was no UNOS, there was no OPO, there was nobody to help you in the middle of the night.
Right.
Our guys ran out there and brought back a heart, and we put it in. It was a mismatch. The guy started having
Hyperacute rejection.
ventricular tachycardia and fibrillation, and then he'd get shocked and he'd be okay for a while. So I ran in and put a total artificial heart in him. Well, something like 12 years later, he finally died of renal failure, which it was late onset. He had perfectly good kidney function, and his whole body functioned very well with the total artificial heart. So we had total graft failure.
Right.
And again, we were able to save a guy by taking action in a situation where if we'd deferred to ECMO or some lesser support kind of system, we probably would have failed. So, the total artificial heart requires that A, you believe in it, and B, you're willing to use it when you see the opportunity. And if you do that and you don't select patients who are hopeless, then you're going to have a pretty good experience.
So now you've got all these TAHs. How did that you successfully were able to do? How did you then take it to the next level so that people started noticing and adopting the technology and looking into using it for their own centers?
Yeah. Well, when we got the technology, it was given to me. Symbion came to me and said, "We're in big trouble with the FDA. We have not reported properly, and we've been too commercial, and the FDA has taken away our investigational device exemption. So we can't put in any more devices in the United States. So we moved the company to Canada,
okay,
so we can supply Europe, and we want you to take the company." And I said, "No way. I'm just a cardiac surgeon. I'm not going to do this, but maybe I can get the hospital to do it." So the hospital stepped in and took over this device for about 10 years. Moved the company down to Tucson.
Okay.
And in the meantime, we organized another investigational device exemption. That was 5 centers that put in about 90 total artificial hearts. And that formed the basis of the New England Journal article that we published in 2004. And that formed the basis for getting approved by the FDA for commercialization. And then 4 years later, CMS came along and said they'd actually pay for it. So, all of those things have to happen before people want to use it. And the other thing was some very bright guys figured out some portable technologies so
right,
patients could go home. And by this time, it was clear that if you had a technology with mechanical circulatory support that enabled patients to get out of the hospital, you could reduce the cost.
Right.
Insurance companies would buy into it, and the government would buy into it. Third-party payers would pay for it, and therefore hospitals would allow you to do it. And in fact, that's what happened. So that's how it marched forward. And in Europe, it marched forward at La Pitié Hospital, where they really became very much in love with this device. And they've put in around 250 total artificial
right.
at Pitié Hospital. Bad Oeynhausen put in quite a bit.
Yeah.
And
that's
were
where when El Baniosi was out there, right?
Yeah, Baniosi. Rainer Korfer was the head surgeon there. And they put in, I don't know how many, over 100, I'm pretty sure.
Yeah.
And there were a few other centers like Virginia Medical College, which is now Virginia Commonwealth University. Yep. And they've put in over 100. Then Francisco Arabia, who was one of our residents, went off to the Mayo Clinic in Phoenix. He started putting these things in. He's up to about 100, and he's been putting them in like crazy out at Sinai, where he's been chief for I don't know.
Yeah, Francisco, good old Puerto Rican boy too. I mean, I'm proud to say he's another successful Puerto Rican surgeon that has made it into the heart failure world.
Yeah, he went back from our program to Puerto Rico. He was very successful there, but it was too successful. He was so busy that he had no life, and he wanted to come back in academics and get into mechanical devices. So when he saw us doing this, he came and he said, "Can I have a job?" I said, "Sure."
Yeah.
Join in the fun, and he's been a great success, of course, ever
So,
since then.
so tell me how's TAH evolved since when you started doing it back in the 80s to what we have today. I mean, you touched a little bit about on the controller side.
Yeah, I think that the main things that have happened are that the device has become accepted generally, but the business end has been very hard to manage. Basically, what happened is we had some businessmen running the company, and they didn't really know too much about biology, and we got involved in designing a driver, and that cost the company about $20 million. Then they wanted to design a polyurethane valve, and that cost some odd millions of dollars. And finally, we wound up going back and rejuvenating the old Medtronic Hall valve. And then the SPUS, which is the basic product from which segmented polyurethane is made, is no longer made. And so the company had to start making it. And they're the sole supplier of SPUS now. So all of these things cost money.
Right.
And this company was funded basically by local investors. So what happened is, they rather than risk their money, the company decided to borrow money to pay for all of these debts that were accumulating, because they were accumulating much faster than device royalties and payments were accumulating.
Right.
And they got so many debts that they couldn't pay them, and so they got into some financial trouble basically.
Right.
And they've been bailed out, and the company now is coming back. There actually were 16 devices implanted in January. I don't know how many in February, but it's been a very good year, a turnaround year for the device. And the number of implants per year worldwide has been in the range of about 150 to 160 for most years for the last 10 years or so. And now there have been over 1,800, I think almost 1,900 total artificial hearts implanted. And I think there's a growing interest in the device, and there's a realization that pulsatility is important,
right,
and that right ventricular failure is important, and that this device takes care of both of those issues. It has very low thrombosis, or it has almost no thrombosis, none.
Right.
You don't have to replace these devices, and the thromboembolism rate is very low as well.
So
infection rate is low, so complications really are not high if you choose a good patient. If you choose somebody that's been on dialysis for a couple of weeks, then you're
asking for trouble.
The wrong patient, yeah.
So if you were to, so let me say that if you then would give advice to, say, anybody who's thinking about jumping into this technology, okay, yeah, what are some key points that you would try to tell them about creating a program with this technology or around this technology? What pearls of wisdom would you actually tell them?
Well, I think I just reiterate what I've told you already. As I see it, the main issues are trusting in the device, that it will work, and I guarantee you it will work.
Yeah.
Then selecting patients who are good candidates, and not holding back, not waiting, not lingering and being indecisive, but going ahead and doing the procedure, and things will work out.
So so with selection is a really key component of the success of the program, and any program that you have. But what is the perfect patient? Because so many times, and I agree with you, we've got the guy who's got, external bivads, or they have, the Rotaflows or whatever flavor of external mechanical circulatory support you want to have. Yeah. And they're in the unit, and they were say, you know what, we're going to put a TAH in him. So tell me what Jack Copeland's vision is of perfect patient to have TAH?
Somebody who's a transplant candidate, because this device is only approved for bridge to transplantation at the present time. There is a destination therapy study going on. There have been some patients enrolled in that study, but basically this is a bridge to transplant.
Okay, so in your experience, is it more like the Intermax ones that we should be trying it out on?
Yeah, it's Intermax 1 and 2, and it's people who, in your mind, they're a good candidate for transplant, but something happened. Usually it's a cardiac arrest or low output, or they needed extra support, or they wound up on an Impella pump or a an external support of some kind, and they have biventricular failure. If they think they have biventricular failure, why mess around?
Right.
That's something that works.
Well, and you're going to take out the right ventricle anyway, right? At the time of the transplant, it's going to go out. So why wait, right?
Exactly. If you've identified a patient as a transplant candidate, you'd love to cut his heart out. I mean, that's what it's all about, isn't it?
Absolutely.
And so why be reticent? Why be slow to use this technology, which works? Because what that does is it allows the patient to deteriorate. I mean, this whole Intermax status thing is very real, and everybody goes through it as they die. And Intermax 1 is the last thing you go through before you're dead. That means there's only a short period of time to take action. Intermax 2 is pretty close to that. I mean, you're on inotropes and you're unstable and you're going downhill. You have more than just hours to days, maybe a little bit more. But those are the kinds of patients. If you've identified them as transplant candidates, if they have decent kidney function, decent liver function, absent of cirrhosis, and all of the criteria that we go through to screen patients for heart transplant, then you've got an ideal candidate. And something has happened over a fairly short period of time to make that patient worse. He's ideal to be supported so he can get back to that point where he was when you thought he was a good candidate. And those patients, even if they're oliguric or anuric, about 90% of their kidney function will come back. If it's acute, if it's chronic, well, maybe around 70% will come back. But it's amazing. No urine output whatsoever on dialysis. And a lot of these patients will come back and never need dialysis after their transplant.
So where does Jack Copeland see the technology, or where would you want the technology to go? If you had a crystal ball, what do you see in the future? What would you like to see in the future for this technology?
Well, my assessment of what's going on right now is that a lot of the sickest people are not really opportunity to survive. They're being treated to death. That's the way I put it. They get more and more medical therapy and more partial support therapy until there's no hope. Right. And my idea would be that there is a significant number of these patients. In our own experience, in our own program, we never put any device in any patient unless we thought they were very sick. And if they had biventricular failure, we used a total heart. If they had left-sided failure, we used an LVAD.
Right.
If they were too small for a total heart, then we used an external biventricular support.
Right.
And, I think that's the way I would do it.
Perfect. So I heard you were up there in Detroit with my good friend Themis Shamaderjakis, and you doctored him through a TAH. How did he do?
Sorry, I just lost you.
No, I was saying that I heard that you were up there in Detroit with one of my guys, Themis Shamaderjakis and Henry Ford. And how did he do?
Great. That case went extremely well.
They transplanted that. They later on transplanted that patient, and he did a second one, the second TAH, and I think the second TAH in Henry Ford, and the patient did extremely well as well.
Well, I'm happy to hear that. I didn't have that follow-up.
Yeah, no. So I've heard from Themis, and he's very excited and very appreciative of what you did. Well, Jack,
Oh,
listen, I want to thank you again for taking the time. I know that you're actually getting ready to go to Nice. I figured I'd get you today rather than getting you tomorrow before you get on an airplane, or the day before you get on an airplane. But I really do appreciate the time that you put in to talk to me today. I know that the listeners are really going to enjoy this interview.
well, it was my pleasure. Thank you for allowing this to be available to some people who might be interested and might use it. I think it's a useful thing.
Well, thank you, Jack, again. And listen, to all listeners, thanks again for tuning in at the Ask Dr. Gonzo Anything channel here on YouTube. This is Gonzo Gonzalez and Talking Points, and signing off. We'll see you in the next episode. Thanks.